thank you for the invitation, and I will focus, as Dr. Richman and Schaefer said, on the resistance, particularly to the new HIV drugs. So just I would like to make a summary of what we are today. We experience an evolution of antiretroviral therapy. So in the beginning of the early 80s, we didn't have a treatment, but as Professor Richman said, after the late 80s, we were able to treat the patient with zidovudine monotherapy, and after with sequential NRTI monotherapy and the dual NRTI therapy. And at that time, the drugs were with low tolerability, and the clinical aspect that the clinicians were really addressing is to avoid the death and the opportunistic infection. And the target of the antiviral treatment was efficacy and effectiveness. After, with the advent of the discovery of the first protease inhibitors, we could start with the heart, and but still we were having a high number of pills, and we start to have as a clinical complication lipodystrophy and not so good quality of life yet. But the goal, the target of the treatment was now the durability. And in the early of the 2000, we were starting also to work on deferral of therapy. But on the late of the 2000, with the start trial, we saw how it's important to treat the patients as early as possible. So we started the early initiation of therapy, and we started to have a few pills, particularly the single tablet regimens. And now the clinical target issue, particularly, is the aging and comorbidity. And the target, of course, is sustainability. And finally, where we are now. Now we are with the rapid heart, test on treat. We try to treat the patients as soon as possible when an individual discovered to be HIV infected. We start to have treatment that we can use as a long-acting. And so which are the clinical aspects now? Today is the frailty population, and we are as a target a lot of studies on eradication. So in this period, we have some new drugs, particularly why we need new drugs, particularly for patients that have multi-drug resistance that previously failed the treatment. But not only, of course. So I will focus particularly to some of the drugs that have been recently approved. And why, first, to say we have multi-drug resistance people that are frequently highly treatment experienced, but not all the highly treatment experienced patients are multi-drug resistant, we should remember. But normally the people that have multi-drug resistance are heavily treatment experienced, people living with HIV, because they have the previous story of zidovudine monotherapy, the sequential monotherapy. So, and on that, all of this reason, how Professor Richman elegantly showed you before, and particularly if the patients, even if it was highly adherent, but after they were not managed to fail, they managed unlikely to fail because the treatment was not so potent, we have a lot of development of resistance. Now, of course, we have early initiation of therapy with better treatment, with higher genetic barrier and more potent. So today we have less selection of resistance virus. So this is very important. But the multi-drug resistance, so are normally older people that have been treated in early days of heart. And also, we should not forget about younger people that acquired the infection with a congenital by vertical transmission, and particularly also individuals that the transmitted drug resistance has been occurred. Why is important the multi-drug resistance? Because we know, and for the sake of time, I cannot show, but still in our study that we currently did in Italy, still the patients that have multi-drug resistance are at high risk of death. At that time, of course, we didn't have yet the new drugs like darunavir, maravir, and particularly altegravir, that was the first class that save these patients. So the multi-drug resistance is an issue when we have the patients. And here we can see how this is in line with what I said to you before. So we are doing resistance tests for many clinical centers, and you see here more than 30,000 isolates, how we see the changing scenario of the resistance over time. So from the beginning to 2010, there is clearly a decrease of resistance. You can see the white bar that is failing without resistance, that is increasing from 15 to 40%. But after this is stable now around 60%. And so we have around 40% still from 2010 that have persistence of resistance, and some patients, you see, around 5% with at least triple class resistance. And of course, we see an increase of the integrase resistance, and the patients that fail with integrase resistance are particular, you see, 34% when have 3 classes resistance. Why this is important? And you know that Bobo Schaefer is driving and is analyzing and supporting all of us, providing the Stanford database that we allow with this system to calculate the genotypic susceptibility score. So each of us, if we have a virus that is resistant, we can see if the drugs that we provide together with the treatment that we want to provide they could be active. And so even if this slide would show us that even if a patient have a triple class resistance and was given after the resistance test a full regimen, the patients did not achieve less, achieve a probability of virological success 100% after the previous failure, while patients that have triple resistance and the poor regimen, so not all the regimens were really fully active, you see that the probability to reach the virological success was 62%. Overall, there was 87% of the patients after 1 year, they achieve virological success after a previous failing. So I will start to speak a little bit about these new drugs, and very important, of course, is as a new mechanism of action is lenacapavir, that in this moment is granted to use for European Commission in UK, and that is submitted by FDA to FDA for approval, and now we can use particularly for treatment of adults with multi-drug resistance infection, where there is no possibility to have too many other active drugs. But of course, this is a very interesting, very potent in vitro with picomolar potency, and is the first-in-class capsid inhibitor. And of course, since it has a different mechanism, is sensitive to all HIV drug resistance virus with all the classes, and is active against CCR5 and CCR4 tropic virus. And what is the peculiarity? That this drug bind the capsid and allow with the 3 different mechanisms to inhibit the viral infection. First, inhibit the nuclear entry of HIV DNA that is mediated by the capsid, and after, of course, the viral assembly of the capsid, and finally the assembly and the virus assembly and the release. And this drug we can use as oral administration, but also subcutaneous every 6 months. And so it's been used now so far for treatment, and they are starting also to think to do also as a prevention. Here, what we see, how this drug was able, in the first graph, you see in the randomized group, so there was people that were for 14 days with a placebo, so containing the failing regimen, and the people that receive lenacapavir. And you see that there was a very big decrease of from baseline viral load on these individuals. and the efficacy was maintained in both cohort, non-randomized and randomized cohort. So overall are 72 patients, and you see how there was a good efficacy here after 26 weeks, also with the recovery of CD4 cells. And here are the new data that have been presented with just about the randomized cohort. And you see that at week 52, excuse me, there was still a very good maintenance of viral suppression, even if it's minus 50 or minus 200 copy. And the efficacy was changing, of course, to the active agents on optimized background regimen. And you see that, of course, if there was no full active agents, 0, you have 67%. So still 4 out of 6 responded, while if you have more than 2, of course, 94% of activity. So very important. But like all the drugs, if a drug is active against the virus, we know, and Professor Richman showed us, there is a development of resistance. And so also in vitro, they were testing different assay, you can see here with the passages, and we saw the development of 7 mutations at 6 particular amino acids. And so, of course, the new of our list of the mutation, we describe for the first time the mutation that are associated with lenacapavir. And the first have been identified in vitro, and particularly you can see that 2 of them, M666I in combination with the 67H, can have a very strong fold change of resistance. And also, interestingly, that normally, if there was this resistance anyway, you see that the virus did not replicate very well. So you have a very low replication capacity. An important message is that we don't need so far to do the baseline test resistance for lenacapavir, because there is, even if the capsid is quite polymorphic, but there is no natural resistance. These are 2 studies published with 1,500 individuals that they did in France, and in a recent paper in Cameroon, in collaborating with us, they retrieved more than 2,000 sequences of drug-naive individuals. And you see that according to the different subtypes, there are some polymorphism, but indeed there is no, very rare, less than 1%, 0.1% about resistance in naive patients, so that have not been treated. Of course, when in the phase 1b study, the post-monotherapy analysis reveal the emergence of low-level resistance Q67H in 2 participants. Particularly, you can see with the low doses of lenacapavir. And this is interesting because this mutation, as you can see here, has the better replication capacity and also low resistance. So in some way, was this the reason that probably was selected? And in the patient that fail the Capella trial, so the patients that have been treated with the multi-drug resistance virus, you see that there are some patients that fail. The majority are failing with the M66I, that is the mutation that is very important also in vitro. And the majority of the mutation that you can see have been previously identified during the selection for in vitro resistance. What is important that so far the patients did not emerge new resistance to the other component of the optimized background therapy. So about the genetic barrier of these drugs, particularly when is functional monotherapy, you can have the risk to develop the resistance, but not all the patients fail with the resistance. This we should say. And another important possibility to use lenacapavir, as I told you, is also in the drug-naive patients. So the long-acting is a very interesting approach. And here you can see the long-acting with lenacapavir that has been used with FTC TAF, that after have to switch to TAF or bictegravir, or lenacapavir with oral administration, or with the comparison bictegravir FTC TAF. So you see that there is a very good virological suppression maintenance at 28 weeks. There were 2 failing patients with the resistance, and again is the same mutation, 67, and together with the 70R. So we start to see the few patients that fail. Sometimes, of course, they fail with resistance and with the mutation that we know. So again, speaking about multi-drug resistance, why we need these new drugs? Because they could, you see here, have an efficacy, and you see how here there is the first endpoint of all of these new compounds that have been approved for treating patients with multi-drug resistant virus is normally at 1 week or 2 weeks to see a decay of HIV RNA. And you see how ibalizumab, fostemsavir, and lenacapavir have a good efficacy. So now, speaking about another drug that has been already approved by FDA in 2020 as a first-in-class oral attachment inhibitor that binds to the GP120, here we can know that there is no consensus yet about the resistance mutation and pattern. So for us, we didn't put a signature on the bars on our list. But we know that particularly some subtypes, there is some heterogeneity of activity, and with subtype AE, you see that there is no activity. So we in some way recommend for the country where there is a more prevalence of this recombinant AE to do the subtyping, could be important for usage. And so far, there is, in the NRS, there is a list of the 4 positions that have been associated with the resistance in vitro. And indeed, 2 of them, the 375 and the 475, are very frequently in the recombinant AE. Some of them are little present also in subtype B. So we need to know, and but today we don't have yet a correlation of baseline resistance and activity of the treatment. But what I wanted to show you here, that seems that the best way to find predictors of efficacy of this with fostemsavir with the high treatment individuals is when you combine a susceptibility combined by genotypic susceptibility score and the phenotypic susceptibility score, but not for all the drugs, but specifically when you are using new usually drugs. And so here you see indeed with the red dash that of course are less people, 70 patients, but you can see clearly a better efficacy respect to individuals that have no active drug at all. The other drug that I want to mention is ibalizumab. That is a first humanized monoclonal antibody that can bind to CD4 when CD4 is already bounded to GP120. And the GP120, particularly, we know that there is a specific region in the V5, that is the variable region 5 of the GP120 that is rich of glycans, are essential for the binding and the blocking. And so as a resistance, so just to say that the glycosylation is a very important process for which the virus try to evade the immune system, because in this way there is less neutralization and so prevention of immune recognition. But the glycans can play also a role in virus cell attachment. And we know that losing some asparagine-linked glycosylation because there is less functionality activity of ibalizumab. And so here is just an example that indeed the patients that failed fostemsavir develop resistance, but also you can see here he lost one glycosylation site, and particularly more close to the N-terminal part of the GP120 that seems to play a major role of resistance. This is very complicated algorithm, but just to say to you that they are working. This is made by the Max Planck people, bioinformatician, to see that indeed there is a very complex, if there is more glycosylation, and particularly all the two in the V5 loop, there is very highly sensitive to ibalizumab. If there is just one, still, if it's maintained in N-terminal, is more active, is in another position, if it's depending how is the size of the view2. So just to say to you how it's complicated to do so far about resistance for ibalizumab, and indeed we need to do the sequencing of the GP120. Finally, I want to speak one moment about another drug combination that is very useful for as a long-acting, that is rilpivirine with cabotegravir. And probably you heard that there was some, so this combination is very active. There have been 3 phase 3 trials that allow the using of this combination in individuals that are suppressed therapy, virological suppressant, so they can be switched to this combination treatment. And we know that there are several factors that can be investigated. In the beginning, the first failure were individuals who had have tri-Russian in a specific flare study that have the A subtype and particularly L74I mutation. So there was a lot of discussion and about this. And so in this analysis, they analyze all 1,039 participants that were really naive to cabotegravir and rilpivirine, and they analyzed the only 13 virological failures that have been presented here, and they try to understand which were the baseline factors that have been associated. So the most important was the rilpivirine resistance at baseline, but also after the baseline HIV1 subtype A6 or A1, that now we know that there was more probably more A6, but still, because in Russia there is a lot of prevalence of A, and before was thought that it was A1, but now we know that it's A6. And so there is, we know that at least 2 factors between pre-existing rilpivirine resistant mutation, the subtyping, or also very important, because these are injectable antiviral regimen, is the body mass index. So if you have at least 2 of these factors, you have higher risk to fail the treatment, even if it was very successful. You see just 1% of participants have a virological failure. So there was big discussion about this subtype, and A1 and A6. So very elegantly, the group of Daniel Kuritzkes show at CROI that indeed in the A6 virus, when there was the mutation 74L, there was, the L74I polymorphism conferred a great replication to this virus, and particularly when there was also the mutation that are important for resistance, particularly for also for cabotegravir, like 118, 140, 148, and 263. So there was, you see, an advantage in absence of drug, but also in the presence of cabotegravir. So in some way, these findings show that this polymorphism can provide indeed a better replication that can be associated with the virological failure to this regimen long-acting. So Here, it has been presented also at CROI, the few resistance cases of the participants that have confirmed virological failure in the ATLAS studies. And you see that in some cases in the red, you have the emergence of resistance that have not been previously. And you see that sometimes there is also the N155H. And this is the reason why also there is this mutation also for capotography. So there are the classical integrase resistance mutation and the classical that we know rilpivirine mutation. Finally, just to say that it has been presented now at Glasgow. Again, they try to understand which were the factors associated to the failure of this long-acting. And in this moment, of course, is very advantageous. I don't know how is the use you are practicing this usage, but in Italy we are approaching now. So it's a very important possibility to treat with this long-acting event also in the future. And here what they saw at the end, finally, that indeed the best model was again that if you have no one of these factors, rilpivirine resistance baseline or HIV subtype A6A1 or BMI more than 30, so if you have no baseline factors, you have the very low risk of failure. If you have at least one, you have 2%, but if you have at least two or more, you have 19% of failure, you see. And you see that there is a very quite good sensitivity of 48% and specificity 96.7%. So if we want to summarize, we know that HIV resistance is always evolving. Also, when we use more the compounds and when we have new drugs, of course, we need to learn the new sequence, the new resistance scenario. And so if we are speaking about these three new drugs, ibalizumab, fostemsavir, and lenacapavir, we need to think that we need to sequence probably all the GP120 if we want to understand the resistance for ibalizumab and fostemsavir, while for lenacapavir, we need to sequence the capsid that before we didn't do. And about the genetic barrier, we know that ibalizumab and fostemsavir is very low. For lenacapavir is low medium, we still need to identify. And we don't have yet a real genotype interpretation for ibalizumab and fostemsavir, and we surely need more learning from phenotype. And also we start to have some data about lenacapavir, but still we need to learn more from phenotype. So in conclusion, we can say that the resistance testing remains surely a cornerstone of the treatment, and the resistance is crucial for the prevention and management of failure of the treatment. And overall, we can see a decrease of HIV drug resistance at failure, but also as a transmitted resistance. This is very important. We still have a few patients that harbor multi-drug resistance that are at high risk of death. And so this is the reason why we need the surely novel mechanism of antiviral drugs that can play a critical role for such a proportion of these individuals. But after, new mechanism of action can be very good for all the patients, and particularly some new drugs with a long-acting strategy can be really very useful and can change the scenario for treatment and thinking about prevention. If you can provide one injection every 3 or 6 months, of course, make a big difference. And so the evolution of HIV resistant profile follow, of course, the improvement in the regimen setting. So we need always to be updated. So I conclude acknowledging this is a proverb, African proverb that I like always to finish my presentation, that if you want to go fast, go alone. If you want to go far, you go together.